Hello and welcome to webinar 2 of Teaching in Real Time, How Well Does the American Federal System Respond to Public Health Crises? Again, I'm Tom Vance. I'm a professor at Kansas State University, and on behalf of Kansas State University's Center for Social Studies Education, the Center for Civic Education, and the Johnson County First Amendment Foundation, welcome to webinar 2. I thought we got off to a great start last night. We have been looking at various governmental responses to the COVID-19 crisis, pandemic. And last night we introduced our core concept, federalism, as well as federalism's connections to other important core concepts such as individual rights and so forth. And tonight, we will focus on the historical background for the various ways in which our governments, plural, have responded to the variety of public health crises that we've experienced since colonial times to the present. Again, just as a reminder, this presentation was put together like a We the People lesson, an extended We the People lesson, where you spend some time on conceptual foundations that we did yesterday. You spend some time on historical antecedents, which we're doing tonight. And then you spend a significant amount of time looking at a current event or issue, teaching in real time, which in this case is the COVID-19 pandemic. So without further ado, I re-welcome Dr. Stephen Schechter.
Thank you, Dr. Vance. And thank you one and all. Welcome back. Last night, as Tom indicated, we focused on conceptual foundations and federalism as our core concept, as seen through the specialized lens of real time. That is to say, what do concepts and first principles look like when there's a real time issue right in front of us? And how do we study both the issues and the application of those issues to core concepts and first principles? And I noted last night that doing that studying concepts in real time has prospects for students, and it also has perils. And we went through those prospects and perils. And I'm not going to bore you with them again. They're in the outline, including the long outline. You have a long outline. You have a brief outline. And you have teaching resources. So you have a variety of material before you. Tonight, we're going to look at something else through a special lens. We're going to focus on historical development, also seen through a particular lens. This time, the lens is called not real time, but specialized history, namely public health history. And you all have used specialized history of one kind or another, I'm sure, both in your own learning and in your teaching. It might have included environmental history, for example, or gender and gendered history, or race history. In my studies, I've used diplomatic history. These are specialized histories, and just like a real time, they have their perils and their prospects as well. The prospects cut two ways. There are the insights that specialization brings to general and political history, on one hand, and on the other, there are the insights to be gained from applying trends of general history to the study of your specialized history. For example, anyone who teaches 19th century America teaches about the three processes, which you probably know before I even mention them. That is, say, urbanization, industrialization, and immigration. And in general history, we look very briefly at the public health ramifications of those three processes. But what if we take a closer look at those ramifications of, and the public responses to them? What would we find? What would we learn about public health history and general history? We'll do that a bit tonight. The perils, of course, involve cutting specialized history loose from its moorings, so that we're studying public health history or environmental history without any sense or consciousness that those specializations are part of a larger historical context. We don't want to do that. We want to keep our specialized public history well moored and to use the term of art, contextualized. That is to say, put in the context of the times in which they operate, both to understand public history and to say, hey, you know, this general trend applies to public history and it'll tell my students something new or particular about that general trend. So we'll begin with that background in mind. We'll begin with chronology. And chronology, I'm kind of old-fashioned. I go from early times to the present. I use historical periods. These are periods of convenience, but they're serviceable. We'll look at four periods. The first is the colonial and revolutionary war period. The second is the early national period to the Civil War. The third is the post-Civil War period to, we're going to go rather long on this one, to World War II, and then the post-World War II period to today. And then we'll look at some generalizations. As concerns all four periods, I'll say some words about pandemics and infection and epidemics during the period, and then I'll say some words about the public responses to them. So the first period, the colonial period, the diseases that reached epidemic and pandemic proportions. Once again, as I mentioned last time, generally speaking, one refers to local outbreaks, regional epidemics, and national/international pandemics. So the differences in those three terms have to do with their scope of spread. So for the colonial period, the most important diseases were smallpox, measles, yellow fever, and influenza. During the colonial period, these diseases were recurrent because there was no cure that worked. There were many cures that were tried. But although they were recurrent, they were rather short-lived because there were not very large, densely populated cities with tenements in which these diseases could thrive and linger if they occurred in cities. And in warmer climates, namely the southern colonies, there was not an extent of trade that would bring in a constant supply of mosquitoes that would populate yellow fever. So recurrent, but rather short-lived. They were I don't know, treated is particularly the right word, but I'll use it anyway if you don't mind. They were treated by isolation and quarantine, which was a topic, a set of vehicles that went back to biblical times, actually. But in modern times, they're credited as having begun in the city of Dubrovnik in the 14th century. This from a fairly new journal called Emerging Infectious Diseases, a cover showing the quarantine of Dubrovnik, and what's pictured, I can't point to it, what's pictured in the center, in the crotch of the city, is a settlement that was used to house visitors, sailors particularly, for a period of time, so that if they had a disease, the disease would work through them. And in these times, the amount of days was 40 days, and in Italian, 40 is quaranta, and from quaranta comes quarantine. Then you can go to the next slide, which indicates that as early as 1633, there was a smallpox epidemic in Massachusetts that infected settlers and Indians alike. And then below you can see descriptions of the treatment of smallpox, one in 1684 by Thomas Dover, who was treated for smallpox by bloodletting, forced vomiting, and then what I didn't quite understand, being sent abroad until he turned blind and then took to his bed. And the next slide indicating another treatment, this one in 1735 for diphtheria. All well-intentioned, not particularly effective. Then comes the Revolutionary War. Smallpox is rampant, not only in the country at large, but on the battlefield. And 90% of the troops who die of disease. It's at this particular moment that an inoculation, a vaccination for smallpox is discovered. George Washington and the Continental Congress initially forbid its use. They then recant, and George Washington orders all new recruits inoculated. He's a smart guy. He knows that people who get inoculated are going to have a fever for a while. You inoculate new recruits while they're going through training, being uniformed and equipped, and their fever doesn't put them or the Army at risk. So he does that, and it's actually one of the most effective things that he does in the war, because the British troops are not inoculated, they get smallpox, and it puts the Americans at a considerable advantage. On the other hand, there are those who are not particularly crazy about inoculations. If you look at the next slide, you'll see a cartoon of the Anti-Vaccination Society, which shows that inoculations by a pox taken from a cow will result in the inoculee springing forth little cows, as you can count, coming out of pockets, hands, arms, and elsewhere. This takes us to the end of the revolution, and with it our first period. Second period is the early national period to the Civil War, 1793 to 1865. The first period had, by the way, 15 pandemics and epidemics. This second period, far fewer years, has 19. If we look at the patterning of these diseases, there were many more different types of diseases. They're longer lasting. Cholera, especially when they're diseases in densely packed cities, which are popping up now. Cholera is one example. The cholera outbreak during this period lasted for 22 years. So when you think about people getting a little bit tired of COVID, since mid-March, think about being exposed to a disease for 22 years. They run rampant in cities which are densely packed, tenements, contaminated water, filthy streets, air pollution. Same diseases occurred during this period as during the colonial period, but in addition, typhoid, typhus, TB, cholera, an outbreak of the bubonic plague, and scarlet fever, particularly among children. Early on during this period, states passed legislation that takes all the colonial legislation on public health, consolidates them into much more effective laws for administering programs both at the state and local levels in their states. And here's one such example from Virginia, imposing a stiff penalty of $1,500 or 6 months in prison for knowingly infecting others with smallpox. But overshadowed by but all of this is overshadowed by the 1793 outbreak of yellow fever in Philadelphia, which at the time is the nation's capital. It's pictured here. You see the fellow in the back doesn't have on a mask, but he's clearly putting a handkerchief in front of his mouth and nose as he's passing yellow fever victims. Next slide, please. You can't read this, but it's a report from Secretary of War Henry Knox, reporting on the yellow fever epidemic in Philadelphia. He writes, "The fever from all that I can learn is more fatal than ever. Yesterday, a vast number of burials. I do not expect any abatement of the fever before we have rain and high winds. The day before yesterday, we were witness to what appears to me shocking. A coffin was brought to the entrance of Welsh's Alley, where it stayed some time for the man to die before he was put into the coffin. Such hurry must bury many alive." A scary thought. Next slide, please. There, in the city of Philadelphia and in other cities, there were Black nurses. Many whites started spreading rumors that it was the Black nurses who were spreading the yellow fever. disease. Two African ministers write a pamphlet in 1794, the cover pictured here, in which they defend the roles of Black nurses in helping fight the yellow fever epidemic and not in spreading it. Meanwhile, Congress is adjourned. The Supreme Court, U.S. Supreme Court is adjourned. People in Philadelphia flee for their lives. They flee in one of two ways. They flee out to the suburbs, or they flee back home. When they flee back home, by the way, in some cases, they're quarantined by the city or town government that they live in. Alexander Hamilton and his wife, for example, flee back to the city of Albany, and as soon as they get into the city, health officials insist that they quarantine themselves voluntarily in Schuyler Mansion, which was Hamilton's father-in-law's home. It's right on the Hudson River. Meanwhile, back in Philadelphia, as soon as the outbreak, as soon as city officials can, they build a lazaretto, which is an isolation hospital or quarantine station, pictured here. They build it on an island by 1794, where visitors are expected to quarantine themselves. Next slide, please. We're not quite there yet, but you'll have something to watch for a few minutes. Yellow fever spreads to other eastern cities besides Philadelphia, and it lasts until 1798, 5 years. It's in 1798 that the federal government, headquartered in Philadelphia, sees all of this and creates a role for itself, a very important role, and that is to build a network of marine hospitals at every major port of entry, ocean and lake, the Great Lakes bordering on Canada, so that sailors, known as seamen then, could be quarantined. As I mentioned last time, these marine hospitals were not run by federal officials. It would be quite some time before we'd see the creation of the Uniform Public Health Services Commission Corps. So these hospitals were run by state and local officials. 19th century comes along, and with it, a second wave of urbanization, industrialization, and immigration before the Civil War, which is sometimes ignored in teaching, but it's very, very important. Early on in the 19th century, as these cities develop, they are pictured here as nests of disease. The nests are tenement areas. This would be what a tenement area looked like in the first half of the 19th century. And then if you go down a little bit further, Tom, if you can do it. No, you can't do it. Go back up again. Okay. Well, pictured as nests are tenements, which are here, and then kind of one level down from a tenement are shanty areas, which are just shacks built around water and oftentimes a landfill. This occasions what's known as a sanitation movement. That is to say, well-intentioned people, by and large, educated people, usually upper-class people, believe that sanitation can help improve public health, can become an engine of social reform, and can become an engine of personal hygiene and urban cleanliness, and prevent the spread of diseases from poor areas to middle class and wealthy areas. It's kind of a curious combination of norms that involves Darwinian thinking, social snobbery, piety, and eventually becomes the basis of the late 19th, early 20th century progressive movement, the progressive movement of Theodore Roosevelt, not Bernie Sanders. So this idea of the multiple values of sanitation leads to a number of early sanitary commissions, both at the state level and at the local level. Massachusetts is one of the leaders. It has a Massachusetts Sanitary Commission, which in 1815 commissions one Lemuel Shattuck, Shattuck, to issue a report on the importance of sanitation in urban settings, and it becomes a very important report that spreads throughout other states that also create sanitation commissions that typically operate out of state or county or local health departments, which have started to be created. These studies, many other states take up these studies, but these studies, the first of which begins in 1850, are interrupted by the Civil War, which creates public health problems on the battlefield of its own. And these kinds of urban studies are set aside. And next slide, in 1858, you see pictured here a riot of a marine hospital. This one on Staten Island. In fact, the marine hospital was burned. Next slide, please. This is an early photograph of a public ward in a hospital during the Civil War. These are soldiers in the main. It's in the city of Richmond, Virginia. 250 patients are admitted to this hospital in 1 week in 1862. Of those 250, 110 will die, primarily of smallpox, contracted primarily on the battlefield. Abraham Lincoln also contracted smallpox, by the way. This takes us to the end of this second period. Thomas?
And it also takes us to our first question.
All right, I'm ready.
Okay, the question is, and I think reading between the lines, and it's one of my students, a great student, by the way, and she would like you to compare our current experience, if you can, with COVID-19 to something huge like the Black Death pandemic. So before we get too far down the road historically, you know, where in essence, the thrust of the question is, and maybe it's too soon to tell, where do we put the COVID-19 pandemic in world history, in the context of world history?
I sort of wanted to wait till that to the end, but
Okay, we can wait. We can wait if you wish.
let's wait.
Let's wait. And so I've got one other quick question. They want to know why the Marine Hospital was burned.
Xenophobia and fear of infection spreading from the hospital, leaping over the gates to
Perfect.
residents on the island. Staten Island's a relatively small and compact island. It's a borough of New York City. So to the third period, Reconstruction through World War II, a long period, 10 outbreaks during this period, but many of these outbreaks last multiple years once they begin. Cholera sweeps this, and you find the continuation of different types of diseases cropping up in different type of environments. So cholera sweeps cities, yellow fever sweeps southern ports during the late 19th century. The 20th century, the largest, most widespreading and high mortality disease is the Spanish flu, which hits the United States in 1918, lasts for 2 years, is ignored by the president and public officials for fear that focusing on it will take attention away from the war effort. The result is 600,000 fatalities in the United States alone. Other diseases during this period include polio, typhoid, encephalitis, which lasts, an outbreak which lasts for 10 years, and then diphtheria. Public responses during this period, this is the second half of the 19th century and the first half of the 20th century. There are three very important sets of public responses. One involves the growth of government and public administration, which is a national trend that's going on independent of public health and engages public health. The growth of government in cities, in counties, states, and now the federal government during this period. You see the development of city health departments, then state health departments and county health departments in almost every state and most major counties during this period. Then the federal government enters the field. If you remember, their only entry in the past was marine hospitals at ports of entry. Federal government enters more broadly in 1870. They now inspect all immigrants and visitors to the United States. There's the creation of the Surgeon General Office and the Public Health Services Uniformed Corps, marking the professionalization of the federal public health effort in much the same way as there's not just administrative developments, but professional developments at the state and local level. And it's during this period, late 19th century, not too far into the late 19th century, I might add, that the federal government public health office begins to require reports from consuls, COUNSULS, not quite ambassadors, in every country where there's an American presence, including Asian countries. Consuls are expected to report regularly on any outbreaks of infectious diseases in the country in which they're serving. This information comes back to the United States. It's put into a data bank, a federal data bank. State data is put in as well. And these reports are shared intergovernmentally. This may be the first example of, probably is the first example of cooperative federalism, federal, state, and local. That is to say, the sharing of information. And by the way, today during COVID, county and state health officials are talking daily with the CDC. So there's a constant sharing of information, which is very important, as you can imagine. Also during this period, you see the forerunners of the NIH and CDC. And then into the 20th century, during the height of the New Deal, you see federal health assistance to state and local officials coming forth in the Social Security Act of 1935. And then you see the passage in 1944 of what still remains today the major public health act known as the Public Health Services Act of 1944. So there's that first major trend, the growth of government and the specialization of government in creating a public health administrative presence. The second development during this period is scientific research. Louis Pasteur creates the first laboratory vaccine in 1879. It was for chicken cholera. Then in 1881, U.S. Army Dr. George Miller Sternberg and Louis Pasteur separately discovered the bacterium that caused pneumonia and other diseases. You can go to the next slide to see a picture of that. Then in the next slide, in 1894, a group of Cincinnati interns successfully treated a small girl with diphtheria antitoxin, who's one of the earliest uses in the United States. That group of interns is pictured here. In 1894, a forerunner of the Merck Pharmaceutical Corporation in Philadelphia begins production of the diphtheria antitoxin in the US. The New York City Health Department also begins production that year. So you're seeing all along during this period scientific research, developments, treatments, vaccines, discovery of causes of diseases as well as cures occurring sort of in the public sector and in the private sector in tandem. And again, we've seen on a number of occasions the role of the U.S. Army being very important as well. And pictured below, if you can see him, is Walter Reed, who led the U.S. Army's Yellow Fever Commission, which helped discover that the tiny mosquito was a carrier of the yellow fever. Mosquito netting followed in time for use during the Spanish-American War. So if you see pictures of the Spanish-American War with tents and mosquito nets, you'll know that that's one of the first uses of the mosquito net in American military history. Pictured just below that is a yellow fever immunity card issued in 1899 by the Florida Board of Health, which is an indication that indeed people were expected to be tested, and if they were immune, have a card that they could carry with them in case they were stopped. That brings us to the end of our second development during this period, sorry. The third development is not a particularly progressive development. You can have unprogressive developments. It is the shotgun quarantine, which is the American expression of the French term cordon sanitaire, which basically works like this and worked particularly, operated particularly in the South when there was yellow fever, which would be brought in by the mosquito on slave ships, on ships from the Caribbean and Africa. People in southern port cities would contract yellow fever. They would flee the cities out to the country. The people in the country would be waiting for them, saying, you're not coming into our town because you're going to infect us. And what they would do would be to recruit basically paramilitary troops who would surround their small town with weapons and physically prevent the infected from entering their town. Cordon sanitaire was also used in large cities as well to prevent outside visitors and ships from entering the city. New Orleans had one, and it was in fact one of the earliest interstate commerce challenges of a public health policy. City of Louisiana throws up a cordon sanitaire that prevents ships from docking. One of the owners of those ships, a French company, which is sues New Orleans. It goes up to the US Supreme Court. The suit alleges that a cordon sanitaire places an undue burden on interstate commerce and international commerce, and hence exceeds the role of the states. I mean, if there ever was a kind of obvious no-brainer court case that the US Supreme Court could use if it wanted to put a limit on the state's use or power, police power of public health, it would be this one. And the US Supreme Court declined to do that. So when we come to study the current examples of states like New York, New Jersey, and Connecticut today, saying that they would no longer allow people entering their state from other states where COVID is increasing in caseload. You know, on its face, it does look like a disruption of interstate travel. It is a disruption of interstate travel. But if one goes by this earlier case of Compagnie Française, if there were to be a lawsuit against these three states, this doesn't seem to measure up to a cordon sanitaire, which was upheld by the U.S. Supreme Court. So there. This cordon sanitaire is kind of interesting politically. I said we'd try to be relating these things to larger historical developments. Public administration, which was the first development, obviously relates to national historical trend. Scientific research obviously relates. The cordon sanitaire relates, but relates inversely. That is to say, during this period, there's a national trend of a new South and of progressivism. And the cordon sanitaire is an example of the old South, not the new South. So the new South politicians join up with national progressive politicians and interstate corporations that obviously don't like cordon sanitaire either. And they form an alliance that lobbies Washington Congress to develop laws that basically federalize or nationalize public health, taking it away from states and localities and punishing those states and localities that support movements like the cordon sanitaire. This effort doesn't really work. Congress passes short-term legislation that gives the federal government some additional institutional presence in public health. Doesn't last too terribly long, a few years. Congress will not touch any effort to challenge or limit the state's police power in the area of public health. And then the next slide shows the passage of one of these laws, the Biological Control Act of 1902. Then around this time comes Mary Malone, dubbed Typhoid Mary in 1909. She's in the first bed. She is infamous as Typhoid Mary, but she is quarantined longer than any other human being in the United States, by the way, for decades, confined to her home. The next slide shows the U.S. public health. Oh, Tommy.
Next slide.
I said the next slide. I'm sorry. Can you go back, stop? Pictured below, the U.S. Public Health Service officers in 1912. They are one of a variety of unarmed, uniformed federal services. Can anyone think of another? Just shout it out. Comes to your house every day. Mailman. And the next slide. The infamous Spanish flu, which is said to begin in military camps in Kansas. Here is a Topeka for any out-of-staters, Topeka, Kansas. Headline, flu, flu, flu. Next slide. At the top, you can kind of see a warning sign for the Spanish influenza at the Philadelphia Naval Yards. It's a warning not to spit. And then a picture of Franklin Roosevelt 1 year before he contracts polio, which is another disease that rages throughout this period. And the next slide. Uh, this is a certificate that was required of, in this instance, the Philadelphia School District, but it shows that by the time of this certificate, 1922, there were school districts across the country that required their students to be certified that they had been vaccinated. It was not too long ago, in 1905, I think, that in a case Jacobson versus Massachusetts, the US Supreme Court upheld mandatory vaccinations of school-age children. This takes us to the end of this period. And now we start the post-World War II period from 1945 to today. There are 18 outbreaks during this period. The first slide is known as the tush shot. A nurse giving one of the first DPT combined vaccinations in 1948 against diphtheria, tetanus, and pertussis. During this period, there's a decided change in the patterning of pandemics. You have asked about comparisons to earlier times. And as we get to the near present, here is one important comparison, or one set of comparison points. There are more infectious diseases during this period, but their duration is briefer because of vaccinations and other tools to control them. The fact that there are more infections are probably due to increase in mobility rates, both in the United States and in globalization and travelers to the United States. As the period progresses, there are also less recurrences of the same disease for the same reason. That is to say, an increase in successful vaccinations, treatments, and other tools to control these diseases. And quite a few of these diseases are, quote unquote, eradicated. In the 21st century, there has, however, been a more rapid succession of different strains coming to the United States, most frequently of the flu, of influenza. In fact, if you look up the definition of pandemic on the CDC site, you'll probably see it defined in terms of the flu still. So I'm not sure if those comparison points compute long distance, but they're in the long paper that I wrote, and it's available to you along with other comparison points. I would be remiss if I didn't note that despite all of these scientific developments and intergovernmental cooperation, the two diseases with the highest mortality rates occurred in the 20th century. One at the beginning, that is the Spanish flu, and the other toward the end, and that is HIV/AIDS. Now, both of these had mortality rates over 600,000. Those mortality rates are much, much higher than the mortality rates for one of the largest strains of the flu, that is the Asian flu. The toll was at the highest extreme 113,000, and COVID-19, which is now exceeding that number, but still nowhere near 600,000. Both Spanish flu and HIV/AIDS had such high mortality rates, not because of it goes beyond neglect. It's outright cover-up, plain and simple, led by Presidents first Woodrow Wilson and then President Ronald Reagan, and continued for years. And as you will learn, or are learning, there's nothing like the passage of time to increase the mortality rate. I mean, the Asian flu came to these shores in the early summer of 1957, and scientists say that the death toll is twice as high as it should have been, because vaccines were not being produced fast enough. Yet by November, there were 40 million vaccinations, which when instituted, virtually eradicated the disease during that time period. We can see the variety of vaccinations. We saw the tush shot. Here's a photograph of Dr. Jonas Salk, who discovered the polio vaccination, injecting his son, his smiling son. Never seen the son. I've never seen a kid smile like that when getting a shot. And his mother. Oh, Peter is his name. My wife tells me. He is now Dr. Peter. Here's Eisenhower and a brief description of the Asian flu, which I've just talked about. And then a less well-known, but nonetheless really, really important scientist in the realm of discovering vaccinations, Dr. Maurice Hilleman at Merck, helped create the measles, mumps, rubella vaccine in 1971. Very, very important, because most children contracted one or more of those three diseases sometime during their lifespan. 2 decades later, he discovered the vaccine for hepatitis A, by the way. Below is smiling President Ford. He must have been impressed by cheery Peter Salk, getting a vaccination against swine flu. One of the oddest circumstances in American presidential history, in which a president is accused of having responded too quickly and forcefully to control the spread of an influenza outbreak, and is said to have lost the election to Carter, among a variety of reasons, like pardoning Nixon, for the problems that came from too hasty the development of swine flu vaccinations. The Zika virus, if you remember, just 4 years ago. I can't say 4 short years, can you, Thomas? I mean, they're all 365 days, for goodness sake. Almost, my wife tells me. Not vaccinations, but spraying in Florida and elsewhere, controlling this disease. President Obama meeting with African leaders in 2015, discussing progress in stemming Ebola. And that brings us to today, with President Donald Trump signing COVID-19 relief legislation in 2020 and reaching for the proverbial box of pens. And then asking a question of Dr. Birx, who always seems to look at him with this incredulous scientific look on her face, which is nicely pictured here. And that brings us to the end of our history. You can see from the history that there are a number of conclusions to be drawn. Epidemics and pandemics are a continuous part of American history for nearly 400 years since the 1630s. From colonial times to the present, the sources have been both foreign and domestic. We've seen that there are patterns of diseases during different periods, and there are patterns of diseases in different regions. Cholera in the urban north, for example, yellow fever in the mosquito-ridden south. Some diseases have been more widespread and deadly than others. Public responses are symptomatic of general trends in historical contexts, as we've seen. Nonetheless, there are a number of consistencies. One of those, for the purposes of this series of presentations, is federalism and intergovernmental relations. We've alluded to an important axis of intergovernmental relations, first colonial relations between colonial governments and their local governments, then between state governments and their local governments. Then once the federal government begins to get involved, first in the 1790s on the periphery in terms of marine hospitals at ports, but then more and more consistently in terms of cooperation with federal, state, and local officials in professionalization, administrative development and innovation, and the sharing of information, and then later state and federal assistance. Whew, thank you for your patience.
Fantastic, Dr. Schechter. You have stimulated a variety of outstanding questions, and we'll try to get to as many as possible. So in putting COVID, let's go back. Good teachers always do what they say. They pay off their students after saying something. So we said that we would try to compare COVID to, in world history, the plague. And just from the more recent part of your presentation, I would suspect your response would be, so far it pales in comparison.
So far, COVID pales in comparison to the bubonic plague?
Yes.
Yes, it pales by comparison to the bubonic plague. I was going to rush to add because nobody knew what caused the bubonic plague or what to do about it. And the interesting thing is, nobody knows much about what caused COVID-19 or what to do about it either.
But the other bigger difference, though, is the bubonic plague was much more deadly, although they probably didn't keep exact statistics in terms of who tested positive, but we just know from the numbers that it was more deadly.
Yes. COVID's a pandemic. It spreads worldwide. It spreads rapidly. When it spreads, it has a relatively high caseload, but not a break through the charts caseload. Its mortality rate is low. Its vulnerability is among the elderly and those suffering from lung conditions, and racial and ethnic minorities, which is another story that we can get into.
Well, that's actually comes to that's a perfect segue into another question, specifically about Native Americans. And after doing all of this research, historical research, and we know some of the more obvious examples of how disease spread through various tribes throughout history. But the question is, relating that to today, the Navajo Nation, for example, seems to be really hard hit by COVID-19. There seems to be a lot of COVID-19 on the Navajo Nation. And so can you, in your research, did you find other interesting factors about specifically how these diseases impacted Native Americans, whether before the reservation system, forced reservation system, or after?
I wonder if is Bob still out there?
Yes.
Bob would probably be in a better position than I to answer this question.
Well, I
Can
do
you
know.
do that technologically?
I don't know if Bob's available right now. We'll come back to it. Bob, if you're not there or available right now, we will come back to the question about Native Americans in terms of COVID-19 and in terms of these diseases throughout U.S. history. We have another one. Oh, there's Living.
Yeah.
So
I'm not sure.
the question is, Bob, about we've had these.
Yeah, I heard it. I heard it. I was just outside on my phone listening to it.
Okay.
I'm sorry to put you on the spot.
No. I think about the nations quite a bit on other topics. On one hand, it seems as though they're so remote that at first I thought they would be spared. Like, if you want to be safe, go to the nation, because of the lack of numbers of people. But unfortunately, that's not what I'm learning. And I don't know why spread is there, because there's a lot of natural social distancing because of space. But what I would ask you, Stephen, is there seem to be susceptible to diseases that Europeans brought in earlier times. Is that the case with this too? Is their immune system different? And maybe one of the teachers out there knows more about this than I do.
Well, let me speak a little more broadly to a CDC preliminary study of what they term racial and ethnic minorities that include African Americans, Native Americans, and others. And in the CDC study concluded that these minorities are living disproportionately under conditions prone to a higher than normal infection rate. And they go on to list those conditions. The first set are living conditions, living in higher density, in residential segregation, in multi-generational compact households, distant grocery stores and distant medical facilities, overrepresentation in crowded detention facilities. These are the kinds of living conditions that make them disproportionately prone to higher than normal infection rate. And in addition to that, CDC found a number of work conditions, working outside the home, working in service jobs, a disproportionate number working in health and nursing home facilities, and lacking paid sick leave in their as part of their work conditions. And then the third set of conditions that the CDC found, they refer to as health conditions, and these include lack of health insurance, distrust of healthcare facilities, financial costs of missing work, underlying often chronic medical conditions, underlying often chronic medical conditions, and stress from being stigmatized. I'm inclined to think that those would apply to Native Americans who are living on reservations, as well as African Americans who are living in urban neighborhoods.
Excellent. I think that at least that's the best answer we can give, and it was a fairly complete answer. We have a ton of questions here. We probably won't get to them all. We'll try our best. So keep your answers brief if you can, Dr. Schechter.
Okay.
Somebody, you mentioned Reagan kind of denying the AIDS thing, and Wilson not really recognizing the Spanish flu. Are there other, well, I guess Washington at first not really recognizing those problems as well. Are there any other examples where our president or our government officials have just sort of turned the other way on a serious public health crisis?
None that are as well known.
Okay.
There's there is a kind of there was one study, I think it may be in the longer paper, of a kind of a scale of presidents from overreacting too quickly, that is President Ford, to reacting way too slowly, President Wilson and Reagan. None are in the Reagan-Wilson end of the spectrum beyond those two. Eisenhower is supposed to have delayed a bit too long. President Trump is supposed to have delayed a bit too long. Those fall into the category of months as opposed to the denial of AIDS, HIV, which is decades.
Excellent. We have a federalism question, a lengthy one. It says, especially since the New Deal, we expect the president to play a major role in dealing with a national crisis.
Yes.
While the states have played an important public health role in dealing with COVID-19, to what extent has the president failed to articulate a consistent, kind of federal position? There we go. And coherent policy to fully galvanize the power and resources of the federal government to support states in their role. And so even though, I guess the question is, reading between the lines, even though the federal government has responded in some ways to COVID-19, albeit a little bit late, have they gone far enough, in your view? Has the federal government gone far enough to help states in their roles in dealing with COVID-19?
There are three federal governments in that question. One is the president, who I can't remember the adjectives, but has not been particularly consistent or coherent in his policy pronouncements or his rhetoric in the area of public health. There's another federal government. That's Dr. Fauci and Dr. Birx and the CDC, and they have been coherent and consistent in their policies. Talk with the states and county health departments every day. There are excellent working relations among and between them in controlling the spread of COVID and sharing data and reports and guidelines about it. And then there's the third federal government, which is Congress, which is divided, as we all know, into two houses, one controlled by the Democratic Party, one controlled by the Republican Party. each with different policy preferences in terms of responding to COVID, particularly as concerns assisting state and local governments. And they're currently deadlocked in and unable to get beyond those policy differences as concerns COVID, not atypical from other challenges that they face. So you got three answers for three federal governments. Is that okay?
I think it is okay. I think it's the truth. We have another one. Was there a backlash to public health mandates such as mask wearing in earlier outbreaks, pandemics, or is this argument? We have several questions about mask wearing and historical antecedents to mask wearing, Dr. Schechter, and also, if you could if you could talk a little bit about mask wearing and how it's become a political issue or a political statement unto itself, or seemingly so.
That's a very good question. I'm just going to react off the cuff as a normal person. And I'm going to start with perhaps a politically incorrect statement, and that is to say, most Americans' exposure to mask wearing is watching TV and seeing Asians wearing masks and laughing at them, if we're honest with ourselves. So getting to mask wearing after being exposed to television shots of Asians wearing masks and laughing at them ain't easy for a lot of people. It also ain't easy to wear masks. It also ain't easy to wear masks socially in areas where people are saying in grocery stores, hey, you dumb so-and-so, how come you're wearing that mask? It also ain't easy to wear masks when Dr. Fauci and others like him keep saying, look, you gotta wear these masks, but psst, they don't do any good. That is to say, if you're looking to wear the mask so you don't get exposed, you really have to have a really, like a spiffy mask to pull that off. You're wearing a mask so that you don't infect others. It's not that bad if you have a really good mask. Really not that, it's really fairly effective in that direction. When you add all these things up, I don't know, they don't provide a lot of incentive for some people to wear masks.
Okay, we've got several questions, and we only have time for a few more. We have about 10 minutes left. So if you don't mind, I'll go on to the next question.
Please.
Okay, and this is an interesting one too. The Asian flu in 1957, you point out that there were, from February to November, 40 million vaccinations ready. And
From summer to November.
From the summer to November, there were 40 million vaccinations ready. Of course, we're hoping that we get some vaccinations ready for. So the question is, how the hell did they do that? So quickly.
They had
Less
scientists had just found the vaccination.
Gotcha. But do you think that in your research was there less red tape then to bring a vaccination to market, or was it roughly similar in the 50s to today?
I can say categorically there was less red tape in the 1950s than there is today.
Good.
And there's less red tape today than there was a decade ago.
Good. Okay.
It's kind of it's not a U-shaped curve. It's a whatever the opposite of a U. It's a camel hump curve, whatever that is scientifically.
This is an interesting one, and it's asking for a comparison of public health crises to something else, some other sort of crises in our nation's history where the government, the federal government, has left a lot of autonomy and decision-making and implementation to the states. So is there a COVID-19 public health parallel where the some sort of crisis, some sort of problem where the federal government provides some guidelines and guidance and so forth, as they have in COVID-19, and as you mentioned in your previous answer, but allows the states a good deal of autonomy?
Yes. The first one would be the crisis in public education. Second one would be the crisis in law enforcement. Third one would be the crisis in low-level toxic waste and environmental pollution. Though the federal government has its fingers in most areas of environmental pollution, there are still considerable latitude for state and local action. Is that enough, or do you want more?
No,
No, what?
That's
Is that
good.
enough, or you want more?
Just a little bit more, maybe.
No. Go on to the next question.
Okay, next question. If we have a next question.
Oh.
Matt, Ken, Bob, Mark, other questions? My screen's a little jumbled up here.
Hospital burned. Did he ask you that?
You asked me why the Marine Hospital was burned, and I said why. Xenophobia and fear of infection, jumping the fence.
Gotcha. We've done mask wearing. I'm just making sure that we've covered them all. Anybody else want to ask a question? Now's your time. This will be the last question. If you have
I've got one.
Okay.
Stephen, what do you think is the balance between the national government and state and local governments on a response to any pandemic, but certainly since we're living through this one, why not this one? Where's the balance, in your opinion?
The balance requires good judgment, and good judgment depends on the circumstances. So this particular pandemic was different in its circumstances than other pandemics. So the balance has got to be slightly different. I think I mentioned at one point, maybe I did not, that just before this pandemic hit, the federal government was administering 11 different public health pandemic plans. 11 by separate agencies, kind of a patchwork of federal plans. And the Trump administration was roundly criticized for rejecting all of them. But the truth of the matter is that plans don't work particularly well when you come up with a new crisis that has slightly different circumstances. So the balance of power between federal and state governments, or the sharing of power, is going to be ever so slightly different. You got in the space of middle March to middle June, how many months are that? You have 3 COVID phases in terms of government responses. You have the initial closing, then you have the selective and varied reopenings, and now you have post-reopenings as the 3rd phase. I don't know that you had a public health crisis before, Bob, that had these 3 phases compressed within them. So many closing, so many stay-at-home orders. So you have, in this particular instance, I would say an unusually high role for states and local governments to play relative to earlier crises, because of the high-handed, heavy-handed responses that they initially made to mandating stay-at-home orders and closings that probably save lives and probably reduce caseload. So on this one, I think the states play an inordinately, and local governments play an inordinately large role.
And in particular, governors and mayors?
Yes, governors and mayors. And on the last day, we'll talk a lot about whether the balance of power within local government and within state governments ought to change so that the executive has more limits and more controls in their declaration and invocation of emergency powers.
I've heard some people talk about that the virus doesn't know boundaries. So why is there different policies in a state that might be just a couple miles away from you? Is the diversity of response from various governors problematic?
Or Bobby, it doesn't even have to be based on states. It can be, even counties in Kansas or
Correct. My point is that in your first description of federalism, of unum and diversity being the states,
Yep.
Should there be more of a national statement that overrides governors and local areas?
Two answers to that question. First of all, there are federal guidelines. The CDC has a wonderful report of guidelines for reopenings that I've read, and I urge everyone to read, because it's so well written and so carefully thought out and so scientifically based. States and localities and corporations like Starbucks use those guidelines. So the federal government, through CDC primarily, does in fact have a very, very important role to play, number one. Number two, when you say germs don't know boundaries, germs don't know boundaries, that's true. There are no smart germs. But the governments and civil societies inside those boundaries, state A on one side of a border and state B on another side of the border, county A and county B inside of one state, have different policies with different measures of efficiency and success to control the spread of those diseases. And that's, you just need to watch the news and read the newspaper to know that that is the case.
So you think that states are acting more alike than different and using the CDC guidelines so that they are acting more in unison, or are they not acting in unison?
Well, I think that's a
yes and yes.
great question. Well, we're unfortunately
Are we
out
out
of
of time?
time, and you're not in charge. I am.
Yes.
So I'm going to call it here. And by the way, we'll talk. I assume, Stephen, we'll talk more specifically about our current responses
Yes,
and begin to evaluate,
yes,
or at least help the participants evaluate our governmental responses to COVID-19 during the next session, which will be on Tuesday of next week. And then we finish up the last of our 4 webinars on Wednesday, where we turn to teaching about COVID-19 and our governmental responses to COVID-19. And that session, that last session on Wednesday of next week, will be led by Matt Christensen and Ken Thomas, 2 outstanding teachers from Blue Valley Northwest High School in the Kansas City area. And again, I won't bother you with your now that I have your email address, except but for sending you resources specific to this webinar. And we were kind of thinking, we had a roughly 97 people last night. We were kind of thinking, well, if we get 50 or so, we would be in good shape. And geez, we had 81 at our high.
yeah,
So that's fantastic. And the final thing is, I invite you again to invite your colleagues, your friends, anybody who really wants to know. And again, the next session is really more on current day. Now that we've done a little bit of the conceptual, a little bit of the historical, we will really focus a lot of energy and attention on today. So unless somebody else has another announcement from Wamigo, Tom Vaught signing off. Thank you very much, Dr. Schechter. Another great presentation.
thank
We'll
you.
see you all next week.